the new exchange did was find who would be the head of it. And that's a very important thing for someone who's going to run such a complicated institution as a healthcare exchange. And we're lucky for all of us, Josh Sharfstein and the board found Becca. Let me tell you a little bit about her. She's not as well known to many of us here as Carolyn, so let me tell you about her. Becca's the executive director of what's now called the Maryland Health Connection, and she has been in health insurance for over 9 years. She spent 6 years in product development at CareFirst in Owings Mills, Maryland, where she had the opportunity to manage almost every product or segment in the market, including the small and large group markets, the Delaware market, the Medicare market, the HMO, PPO, vision, and pharmacy care management, and affinity product lines. As the director of the small group market, she worked with the Maryland Healthcare Commission to modify the comprehensive standard health benefit plan benefits to stay within its statutory requirements. Ms. Pearce, Becca then moved to Kaiser Permanente to manage the Medicare Advantage product nationally. Most recently, she was the director of benefits administration, where she was responsible for negotiating and implementing benefit exemptions for major national companies throughout the Kaiser Permanente organization. In this role, she also helped to develop Kaiser Permanente's national preventive health package, preventive benefit package required by the Affordable Care Act. Becca has her undergraduate degree from Washington University in St. Louis and her MBA from the University of Maryland, College Park, and she resides in Baltimore County. And again, we are very lucky to have her. And in the short time she's been here, we in the advocacy community have been really impressed and thrilled that she's doing this for us here in Maryland. So, Becca?
Blah, blah, blah. I need to update my bio. There's a lot of stuff there. Are the slides somewhere? Right there. Hi, everybody. As Vinny said, I'm Becca Pearce. I'm the Executive Director of Maryland Health Benefit Exchange, now known as the Maryland Health Connection. So thank you for allowing me to be here today. I'm going to give you a quick background on the Maryland Health Benefit Exchange, talk about the impacts to the individuals and the small businesses, and then where we are from an implementation perspective. So what is a health insurance exchange? You know, the Affordable Care Act lays out that each state is required to have a health insurance exchange by 2014, which is essentially a marketplace where individuals and small businesses can actually go online and search for health insurance. It is not the federal government taking over health insurance. Hi. It is what I often talk about is the Travelocity, the Expedia of really just a website for people to go and purchase health insurance that already exists in the market. The important thing about it, too, is that it's really a no wrong door entrance for people into Medicaid or into the commercial market. So it's not just commercial exchange. It's going to be eligibility determinations for people to figure out the right place for them to get insurance. Ultimately, you know, the long-term goal of the exchange is that it's no longer somebody saying, hey, I need health insurance on the commercial side, or I need Medicaid. It's somebody saying, I need coverage, and the place that I know that I can get trusted coverage and be steered in the right direction based on my eligibility determinations is the exchange. So I'm going to go there because I know there are people who can help me make this decision. And then the exchange itself will do those determinations and point people to the right direction. As Vinny pointed out, we do have the ability to establish our own state-based exchange. We do anticipate becoming a state-based exchange in the very near future. And if we don't do it, then the federal government will do it for us. So when we moved forward very quickly on that, the goal, I think, and has been so far to make sure that we're implementing the right exchange for all individuals, small businesses in Maryland, and for all Marylanders, not what the federal government might come in and do for us. So we've been lucky enough to be able to pass 2 sets of legislation. I'll go through the first set of legislation, which was passed in 2011, and as Carolyn had suggested, sets the exchange up as a public corporation and an independent unit of state government. She calls this the best of both worlds. I don't know if I would call it that. It is a very interesting place to be. There are, being part of the state government is absolutely where we should be. I do appreciate the work that was done in that legislation to allow us to bypass some of the state processes that are in place, and I'll talk a little bit about that later, and the impact on the enrollment and eligibility system. As you saw earlier, there are 9 board members. We have 3 ex officio members. We are lucky enough to have Josh Sharstein as the chairman of our board. And there were 6 appointed, 3 with type of insurance experience, and 3 representing consumer interests. And since my PR person put this slide together, she likes to point out that I was the first executive director appointed in the United States. From a stakeholder engagement perspective, again, just to reiterate what Carolyn was saying, is that this is really not only a tenet of healthcare reform in general, but really something that we've taken to heart at the exchange. We very much have an open, transparent process. All of our meetings are public. All of our board meetings are public. We open all of our advisory committee meetings open for public comment at the end, mostly during. The 2011 legislation did require us to do 6 different studies and create 4 advisory committees. During those meetings last year, so I came on in September, and the first day that I came on board, one of the advisory committees was meeting, and I went to every single one of those meetings that I could. There were several that were at the same time, just to listen to what was going on. There were, it was clearly cross-functional. We had the health insurance industry, providers, we had community members, advocates, local government officials, consumers, and I often tell a story about how during one meeting, it occurred to me that there was a hospital association member sitting next to a broker, sitting next to a consumer advocate, and at the end of the day, they all agreed with each other. And to have that sort of collaboration and for everybody to move forward, it really made the 2012 legislation pretty easy. I'm just going to jump to and come back to some other stuff. So those advisory committees laid out so the board needed to make some recommendations to the General Assembly. On December 23rd of last year, we owed a report to the General Assembly on how to be an effective exchange. All of those advisory committee discussions actually led the board down this path. And although there were a lot of somewhat could have been perceived as dicey discussions, it really wasn't so, because all those advisory committees came together in unison with a direction for an exchange that was right for all Marylanders. So those recommendations actually transferred into legislation. It was an administration bill written by Carolyn, so we very much are connected at the hip. And the 2012 legislation lays out, among other things, it defines what the Navigator program is going to look like compared to the producer market, and I'll get into that in a little bit. It really got into how do we make sure that the health insurance exchange does not become a high-risk pool? How do we make sure that that carriers are playing equally, that we have the right plans, that individuals aren't going to be adversely selecting either for or against the exchange? It really was a lot of policy work that went in there. Let me actually just go back to this. From a stakeholder perspective, we do have a stakeholder site that is visited on a regular basis. Going back to our public piece, all of our minutes, or all of our presentations are on here. All of our upcoming meetings are on here. All of our requests for proposals are on here. All of our jobs are out here. I'll get into that in a minute as well. So really someplace that people can go and get information. And Carolyn did get into this a little bit about the Affordable Care Act and why the Affordable Care Act is important to Maryland, but I want to talk about why the exchange is important to Maryland. It expands access to our 13% of uninsured. So currently we have 730,000 people. I think it might be up to 740,000 now who are currently uninsured. So those people today are currently getting their insurance through the hospitals, going to the hospital because they don't have any other place to get it. It gives individuals access to primary care physicians and preventive services. As Carolyn talked about the federal subsidies, it provides an influx, and this number is actually old, and you saw on Carolyn's, it's actually $600 million of federal subsidies, new influx into our system. And as you saw on her slide as well, the Affordable Care Act in general creates 9,000 jobs in the first year, 26,000 jobs by 2020. So all of these new funds in the system and the way that people are going to be changing the way that they're actually using health insurance is really going to modify and is going to create jobs and really just infuse a lot into Maryland. Ultimately, we're looking for it to lower uncompensated care. Obviously, Vinny talked about short and long-term needs to change the way care is delivered. From a short-term perspective, the exchange is really focused on just getting those uninsured in the system. We want to make sure that we've got enough carriers in the market to offer enough plans that are interesting and enough to offer people in the market. So we're starting with an any willing carrier model. Then, as we start to get enough oomph behind us, enough people that we can actually start working directly with the carriers to change the way that they're delivering healthcare. It could possibly be, in 2016 or 2017, hey, listen, you need to have a patient-centered medical home to be able to offer on the exchange, or value-based insurance design, or whatever the case may be, so that once we get the market behind us, that we can actually say to the carriers, okay, we've now got enough market force behind us that we should really be working on it. That's when we're really going to be able to start changing the way that healthcare is delivered. And so that's the long-term goal. The short-term goal, like I said, is really just to get people in. So Maryland Health Connection, a little bit of information about what Maryland Health Connection, which is the portal and entry point for individuals into Medicaid and to the exchange. It is the only place that individuals are going to be able to get tax subsidies and cost sharing reductions from the federal government. So the federal government is going to give federal subsidies for individuals under 400% of the federal poverty level. As you can see, that's about $44,000 at the bottom. Let me just use an example of somebody at 200%. So 200% of federal poverty, they're making about $22,000 a year. The maximum amount of pocket that they can pay in premiums is $115,000. I mean, $115 a month. They can only pay $115 a month. It doesn't matter whether the health insurance on the exchange costs $300, $600, whatever that number is. The federal government is filling that gap between $115 and whatever that premium is. So that's where that $600 million of federal subsidies come into the market to support the system. So this is really how, when people question, how is it that people who couldn't afford health insurance before are going to be able to afford it now? It's these federal subsidies that are going to be able to allow them to get insurance. And how are they going to get access to that? So first and foremost, we do have MarylandHealthConnection.gov, which is our portal. But we know that health insurance is not so easy to buy. It's not so easy to understand. So everybody's going to need assistance. We are required by the Affordable Care Act to set up a Navigator program. I'll get into those in a little bit. We absolutely need brokers and the producers in our community to support us. We estimate that we can enroll between 150 and 180,000 people in the first year of the exchange. There are 180 days in our first open enrollment period. That's 1,000 people a day that we need to enroll. There is no way that we are going to do that without the brokers and producers in the community that already sell insurance. So we are very much working with the producer community. We are very much ramping up the Navigator program. The Navigators, so the Navigators will essentially be helpers in the market, need to understand the enrollment and eligibility program for Medicaid all the way up and through the tax subsidies and in the insurance market. And so we are going to need a lot of feet on the street from a Navigator perspective, helping people understand what they can do. The Navigator program and the broker program are going to supplement each other. We will also have a call center that will be all-inclusive call center so that carriers can call, individuals can call, small businesses can call, really a hands-on call center. And then we'll be doing outreach and education. We'll be starting our advertising campaign probably June or July of next year. Don't want to do it too soon. We'll have to have our call center up prior to us doing that so that when people see it and they need someplace to call, we can answer those questions. But we will, as starting today, we'll continue to be doing events and business outreach and things like that. So just a little bit more about the producers and navigators. The Affordable Care Act requires that navigators conduct public education and outreach, distribute fair and impartial information, and offer information in a culturally and linguistically appropriate manner. So when we took a look at that and we determined what the legislation was going to be for 2012, we wanted to make sure that we were, the 2011 legislation made sure that we did not replace the market, that we supplemented the existing market. As we said earlier, we wanted want to make sure that the exchange is right for all Marylanders, and that means not necessarily upsetting the existing market. So I often say that I personally, in the exchange, we're not focused on those people who already have insurance. If you already have insurance, great. Stay where you are. We want to focus on those people who are uninsured and make sure that they're getting into the system as much as they can. So navigators, if somebody is already working with a broker and that navigator recognizes that they're working with a broker, they need to refer that individual back to that broker so that we're not taking business from the existing brokers. Brokers, as I said, very much we want to work with them. They do need to receive training from the exchange to be able to do that, so they're up to speed on exactly what the system looks like, understand what the tax subsidies look like, and what the oversight is. And from an oversight perspective, the Maryland Insurance Administration, we work very closely with the Maryland Insurance Administration on all of these functions having to do with the insurance side. They have oversight of these programs. So what can individuals do right now to get health insurance? And taking a look at marylandhealthconnection.gov, which is up. It is a placeholder site right now. You can link to, it does have links to a couple different places like the Maryland Health Insurance Plan, which is our high risk pool, has links to the Maryland Insurance Administration if you have questions about insurance. A couple different, it has links to the Governor's Office of Healthcare Reform website. So it is just a placeholder right now, but you can sign up for email updates. You can sign up for text updates, text connected to 69302, and you can get information on what's going on at the exchange. So then moving to small businesses, because the exchange isn't just for individuals, it's also for small businesses, and it's what the federal government calls the SHOP program is available for small businesses up to 50 employees, which is the current size of the small group market, at least until 2016. In 2016, the Affordable Care Act modifies that small business group to 100. But this is a place where it's the only place, as with the individual exchange, it's the only place that small businesses can get tax credits. And I'll get into the tax credits in a minute. But we will provide employers an innovative, the plan options, the plan compare for an easy way to administer and take a look at the plans that they might want to offer. Again, it's the only place to get the tax credits. And we also have an employee choice model. So today, if you look at the vertical under Carrier B, small businesses, so groups under 50, can only purchase one carrier. In the large group market, so anybody over 50 can purchase, the HR person can go in and say, hey, I want to offer Care First next to Kaiser, next to Aetna and Cigna, and that employee can go in and choose any of those across the board. But in the small group market, they're limited because the carriers will only allow to offer one. So the Affordable Care Act requires us to be able to offer employee choice. So if you look at the horizontal, what that employer is going to do now is to say, okay, employee, I'm going to still give you your contribution, whether it be 50% or $200 or whatever the case may be. I'm going to choose a meta level for you, and you can choose any of those carriers on the market. And the important thing for us on this is it introduces portability in the small group market. So if I leave ABC company to go to DEF company, I can take that health insurance with me. So the continuity of care between moving from, I don't have to move from carrier B to carrier C. I can take carrier D with me. So that continuity of care and the transition really makes it easier. And that's another way to lower healthcare costs in the long term. So from a tax credit perspective, today there is a tax credit available for small employers. It's 35%. In 2014, that raises to 50%, but you do have to have fewer than 25 full-time equivalents and an average annual wage of less than $50,000 a year. So this targets probably those groups that haven't been offering health insurance before. In 2014, today you can get it anywhere, obviously. In 2014, the exchange is the only place you can get it. So what's next for small businesses? Again, small businesses can go to marylandhealthconnection.gov. We are encouraging them to talk to CPAs, talking to their brokers if they're already working with brokers to understand what changes might be coming down the pike for them. And then quickly just to talk about our implementation. So, as we mentioned, in June of 2011 was the first time that the Exchange Board met. I came on board in September. And so the Maryland Health Benefit Exchange has received $157 million in federal funds to date. We have spent no state funds on anything that is Maryland Health Benefit Exchange specific functions. So we have the planning grant, early innovator, and establishment 1 grant were all received prior to me coming on board. Those are probably about 90% IT based. And then the level 2 establishment grant we just received in August. That's $123 million. That covers us through the end of 2014. This again is probably 60% IT based. So very much, and I'll get into a little bit of detail about what we're doing with those IT funds. We are looking at a new eligibility and enrollment system. So through the Maryland Health Benefit Exchange, the state procured a new enrollment and eligibility system. This is one of those places where we were lucky to be able to be nimble enough to maneuver through the system. So for example, it took us 5 months from the time that we put the RFP on the street to the time that we actually brought our vendor on board. The new MMIS system in Medicaid took 5 years for them to bring that vendor on board. So there's no way that if they hadn't thought smartly enough about this early on that we would have been able to maneuver and be in place by next year. We work very, very, very closely with DHMH and DHR on this because DHR owns the current enrollment and eligibility system. DHMH normally is the one who brings in the money through the federal funds. So it's this dance between the 3 of us to try and, as we go through the implementation. The phase 1 of this implementation is for just to get us through October of 2000, to get us to open enrollment and really up and running. Phases 2 and 3 will begin to incorporate the non-MAGI determination, so long-term care, things like that. And phase 3 will bring in the social services so that it's all under one system. And somebody getting SNAP, TANF, doesn't matter what they're getting, it's all going to be enrolled under one system. That is being looked to be complete by the end of 2015. So from our milestones perspective, we did award in March. We began our development in May. We will begin our first round testing in November. The way that we're implementing this on a sprint perspective. So we're looking every 5 weeks. We are testing and beginning and looking at it and testing it and moving forward, as opposed to a long implementation where you don't actually know whether or not it's working until the very end. We test on a regular basis. But in November will be our first round of end-to-end testing. And then in second quarter of 2013, we will be including external stakeholders to continue that tenet that I mentioned earlier about that stakeholder engagement. We'll be including them in the stakeholder testing. We do plan to go live in July so that carriers can be testing with us in the production environment. We'll be obviously testing prior to that in the development, but then as we go live, ready for open enrollment in October. And in terms of administration of the Maryland Health Benefit Exchange, so when I came on board in September, I was talking to a friend of mine and they said, "So where's your office?" And I said, "I don't have one." And they said, "Well, what's your dress code?" And I said, "I don't have one." I mean, I didn't have a computer, I didn't have a desk, there was nothing, right? So on top of also implementing all of this stuff to be ready for the exchange, we're also in the process of actually developing an organization. So we have 11 official members. It's me, and we have a director of operations, director of IT, director of communications, director of plan management, director of policy, a fiscal administrator. We do have 9 contracted program management office members. They're responsible for implementing the IT piece. We do have Hilltop support, and we do have one extra special intern, JP Cardenas, who we couldn't live without. Aren't you supposed to be in the office? Oh, right, okay. And we did just receive 33 pins from Board of Public Works in September, and we currently have 8 positions posted. We will be posting throughout the year. We do expect the organization to be up to about 70 at the end of 2014. state process that we have to go through gives us pins we have to go a couple different times. So instead of getting them all in one fell swoop, we only have 33 right now. But we definitely when we looked at the organization and development, we wanted to make sure that we weren't bringing everybody on board before we needed to. So it's a very slow and measured organization build. And then from a self-sustainability perspective, how is the exchange going to be sustainable? So we must be self-sustainable by 2015. In the way that we started to begin this process, and there were 2 studies required. So in the 2011 legislation, there was required to be a stakeholder advisory committee and a study to determine how we were going to be self-sustainable by 2015. That advisory committee found that the exchange actually benefits more than just those people who are in the exchange, more than just those people who are enrolled in the exchange, and more than just the carriers who are participating on the exchange that we're funneling business to. That the exchange actually benefits all Marylanders because we're going to lower uncompensated care, we're going to lower premium costs across the board. And so the exchange board made a recommendation in that report last December that the funding should be both broad-based and transactional. So again, because we're funneling business to those carriers, they should be paying us just like they pay third-party administrators in the market today and brokers in the market today. They should be paying us for the business that we're sending their direction. So that's the transaction piece. But because it's also a very we're not totally sure how it's going to work out, and it's a little bit volatile for the first couple of years for sure. We want to make sure that we have some sort of broad-based funding mechanism coming in as well. But what we determined is that the 2012 legislative session wasn't the right time to actually address this in detail. And so instead of actually trying to push through a funding mechanism, when there was still some uncertainty, the Supreme Court was still out there, we just still weren't sure whether or not it was going to move forward, we made the decision to actually do another study. And so the 2012 legislation creates a joint bipartisan executive legislative committee to make a recommendation to the Governor and General Assembly in December. We do have 2 senators and 2 delegates on that. And what we're doing this year, different from last year, is we're building on the work that was done last year to move forward with this broad-based and transaction-based model, but we're getting into more detail. So we're working with a consultant right now to finalize what our operating budget looks like. This is getting into details of how much are we going to pay the Navigators, how many people are you going to have on board, like what is the actual operating budget that you have. And we're taking that number and we're going to put actual funding. When you create the broad-based funding stream, what % does that funding stream need to get to your operating budget number? So we'll come back with some specific numbers. The report is out for public comment right now through October 22nd. The committee will be meeting in early November to receive information on the actual budget and to the feedback on the public comment. And then there will be a committee meeting in mid-November to make a final recommendation, which will then go to the report, which will then ultimately end up in Annapolis for legislation in 2013. And so what's next for us? So obviously we're going to keep continuing moving forward on the IT piece. That is our critical path. We have a couple critical paths, but we really need to get to the IT piece up and running. We are very focused on working with the carriers right now because we're trying to build the store, but if the carriers don't come and put their products in their store, there's really nothing for us to sell. So we are working very closely with that. We do have a lot of policy development that's going on right now over the next couple of months to the exchange board. We're working on the Navigator pieces, how SHOP's going to function, how we're going to manage our appeals and grievances program. We do have regulations going through the AELR process right now. We will probably have those continuing through next year, probably further. Like I said earlier, we do expect federal certification when they grant certification. We do anticipate that we will be conditionally certified. We have heard from the federal government that they do not expect to fully certify any state between now in their first round, because I think the exact quote was, unless there's some I can't remember it now what it was, but something about space-time continuum and actually having your IT system up and ready to go 9 months before you actually need it. They understand that that's not going to happen. So they'll conditionally certify us on our policies and our plans to move forward, and then the IT pieces will be check-ins at a later date. As I said, outreach and education, we will continue moving forward with, and an open enrollment is in October. So, fast and furious.